Today's topic is PET CT for general physician, and I have with me Dr. Guru Prasad sir and Dr. Saikrishna. Dr. Guru Prasad sir is guest speaker for the session, and Dr. Saikrishna is expert speaker for the PET CT. So, Dr. Guru Prasad, I know in the Twin Cities he doesn't need any introduction, but I really feel privileged to introduce him here. He is head of the Department of Internal Medicine of Care Hospital, Banjara Hills. He has done his MBBS and MD from most prestigious institute of country. Everybody knows, and every medical student uh, longing to join that place in some time in their career. That is All India Institute of Medical Sciences. And then since then, I think he is practicing in Hyderabad. His special interests are infectious diseases, rheumatology, and critical care. He is actively involved in academics with a robust teaching program for DNB students since 2015. He has contributed in multiple articles in peer-reviewed national and international journals. I welcome you here, sir. We are really privileged to have you here on this platform. So before I ask Dr. Sai Krishna to start his presentation, I would like to hear from you that how do you look at PET CT, in which clinical scenario you use PET CT, and like today in general we normally use FDG PET CT only, but do you look up to few other investigations, a few other PET CT like PSMA and Dotanoc and all that, as well as like neurology and cardiology indication of PET CT? Do how do you see all this? Over to you, sir.
Thank you very much, first of all, for having me in your webinar. I was really, when Dr. Inti Kishore and Krishna Mohan called me, I was really interested in this topic because I think I've been a proponent of actually referring patients for PET scan. And the first time actually I mentioned PET scan to patients, they get scared saying that, like, do you think I have cancer?
Yeah.
So somehow
Yes.
that kind of impression is there among about PET scan that it is generally used for a cancer patient, and
Right.
then I have to convince them that it's got a lot of other usefulness apart from just diagnosing a cancer.
Right.
My understanding of PET scan went back from when I was doing my PG in AIMS, when we had a very nice nuclear medicine department. And I remember one of the first nuclear medicine scan which we did was an MIBG scan for a patient with suspected pheochromocytoma. But I think since then, a lot of things have evolved over a period of time in nuclear medicine.
Right.
I feel my personal clinical experience about PET scan is that it is really useful when we are using as a diagnostic tool once we have exhausted all primary PEO patient. So there we had some really interesting cases come up with interesting diagnosis with the help of PET scan. In fact, I would like to quote one patient who actually went to the US, had a aortic valve replacement. Her RA factor was strongly positive. She had a lot of joint pains, we are suspecting very strongly infective endocarditis. But interestingly, the transthoracic echocardiogram and the TE both were negative. And eventually, it was by PET scan. Dr. Mansoor was there, I think, who reported this PET scan. He was in care at that time. He reported that there's a, aortic root abscess. And
Yeah.
when they went back retrospectively and saw in the T, there was indeed a small focus of collection, and then it was corroborated by a CT iodogram. And
Right.
interestingly, this patient turned out to have a Q fever, right? The Q endocarditis.
Oh.
Uh,
Oh.
he went to Yellowstone National Park in the US, and then she came back. And
Wow.
the titers we did from Mayo Clinic, and they were very high. So eventually, she turned out to have this patient would have gone undiagnosed if he had not used PET as a modality, asked for a
Correct.
PET as a modality for diagnosis of PUO. So
Correct.
basically, I think this underlines the importance of asking for an advanced diagnostic modality like PET. But I think again, a word of caution is that it's not to be used randomly or for each and every patient. It is
Correct.
basically where you have exhausted all your primary modalities of your investigations. That's when a PET is to be used. A couple of concerns which I had was, one is that most common question patient is asked is, what is my exposure to radiation when I get a PET scan done? And also there is any special precaution like blood sugar should be under complete control before we ask for a PET scan. Does it affect the sensitivity of the PET scan? I'm sure that's what Dr. Saikrishna is going to address in his talk. And these are all what the GPs have as a concern that what is the sensitivity of a PET scan and what disease it cannot diagnose, when I should not ask for a PET scan. Probably you can address those. And I think after your talk, because I worked with Dr. Narsimhan closely in Care Banjara, we had a lot of case of cardiac sarcoid where we relied quite a bit on myocardial MR and also as a PET scan for a modality to diagnose sarcoids, cardiac sarcoids. I think Dr. Sai Krishna will address those things. Thank you very
Sure.
much.
Thank you, sir. So I think now we have today's speaker, Dr. Sai Krishna. Dr. Sai Krishna is a young, dynamic, and dependable colleague of mine. He has done his MBBS and MD nuclear medicine from STRIMS Tirupati. Then after that, he has worked in Medicover Hospital, Nellore, and now since few months he has joined Vijaya Diagnostics. He had quite a few publications as original articles as well as case report. So, and here I'll not take much of time. I invite Dr. Sai Krishna to take on and start his presentation. Over to you, Dr. Sai.
Good evening, chief guest as well as the moderator. So it's a great honor for me to have a word with all of you. So today I have been asked to speak about a PET CT and its utility for general physicians per se. So coming to the subject proper. See, what actually is a PET CT is a positron emission tomography. So it combines both CT and PET part. So being a hybrid imaging modality, as all of you know that CT gives us the anatomical details. So PET, what does PET gives is that um, metabolism and function. So it gives us the metabolism and function at cellular level. So what happens is a single imaging modality where both PET and CT can be done in a single gantry. So initially a CT that uses anatomy as well as sometimes it is used for attenuation correction. So followed by a PET. So before this, we will give a small amount of radio tracer, preferably, I mean, conventionally FDG PET CT, FDG what we give. So it localizes in the body, and what actually PET gives is the tracer distribution in the body. So as I said, most commonly used that radiopharmaceutical what we use in PET is FDG PET CT, FDG PET. So F18 is the radionuclide, which is a positron emitter. That is the basis for PET imaging as such. So what is FDG is fluorodeoxyglucose, an analog of glucose. So it has a distribution similar to that of a glucose. So what we see on a FDG PET CT is just the differential increase in the tissue glycolysis. Because of infection or inflammation or malignancy, there will be a difference in glycolytic activity. That difference of glycolytic activity will be visualized on the PET image. So as said, there are some preparatory measures to be taken before a PET CT. Minimum of fasting of 6 hours. So can have plain sips of water, but not to take any sugar containing fluids as well as orals. So diabetics, they should avoid insulin, long acting before the day of scan. So the desired FBS then is fasting blood sugar for the PET scan is 160. So what happens is when the sugar levels in the body are more than certain limit, so they have a competitive inhibition with that of a FDG, so that the scan sensitivity will come down. So the desired FBS is around 160. So should not do strenuous exercise before test, because that also is related to the glycolytic activity. So what happens in a PET CT department is initially normally we check the blood glucose level. If it is in appropriate levels, so then FDG preferably is injected 1 hour before the scan. This is the time we allow for the radiopharmaceutical to distribute in the body. So a whole body scan is done. Conventionally, a whole body scan is done from vertex to mid thigh. Usually a CT is acquired first, then followed by a PET. So at times, lower limbs and delayed imaging can be taken if the initial scan is non-diagnostic, or if still we have a suspicion of any other infective or malignant focus. So apart from oncological indications, as such, PET CT, as majority of you know, 80 to 90% of the times it is done for oncological indications only. Apart from oncological indications, so what general physicians will be interested is that pyrexia of unknown origin. So most of the times we get cases from a physician when the fever focus is not identifiable, or all the relevant investigations are exhausted like that. Other thing is a bone lesion, solitary bone lesion on a routine X-ray or an MRI, which was causing some pain, and then it is non-diagnostic whether it is a infective or malignancy. So at times to identify the infection of unknown origin or carcinoma of unknown origin, we do a PET CT. So a solitary pulmonary nodule, in fact, a solid pulmonary nodule seen on a chest X-ray or as well as a CT scan, how to characterize and how to follow up a solitary pulmonary nodule, and a cervical node which was thought to be a COX and has given empirical ATT but without response. These are the most common indications what we encounter for a PET CT from the general physicians. So coming to the pyrexia of unknown origin, which is a major crunch. So when you call it as a fever of unknown origin, is a temperature of more than 38.3 degrees centigrade. So for at least two occasions, or a febrile illness of more than 3 weeks, or multiple febrile episodes within that 3 weeks, and patient should not be immunocompromised, and relevant investigations, thorough history and physical examination all have been done, but we are not able to find or come to a diagnosis. At that time we label the patient as a fever of unknown origin or pyrexia of unknown origin. So at this point it can be an infection origin or non-infectious inflammatory disease or malignancy, or still miscellaneous causes like drug induced fevers can be there. So all these possibilities can be used. So what actually we search in an FU is the potential diagnostic clues. So based on the history or physical examination or initial investigations, we find some potential diagnostic clues. Based on these potential diagnostic clues, we go with further evaluation. If even though these potential diagnostic clues are not giving any clue, then the role of PET CT comes into place. So PET as a modality is recommended when we don't have any potential diagnostic clues. So this is the chart actually what we follow. This is the uh, criteria for FUO, then history, some antibiotic treatment initially who has not responded. These are the investigations, and then if these potential diagnostic clues are present, then patient will go along with the diagnostic test. If they are not absent, if they are not present, or they are misleading, potential diagnostic clues are misleading, then the role of PET CT comes. So to go with some few case scenarios, so this patient presented with a low grade fever for 2 months, loss of weight as well as appetite, and there was a left supraclavicular node which we can see in FDG PET CT. So that was sampled initially. FNAC was done, but that came out to be reactive. Patient was given some antibiotics, which did not respond for a brief period of 7 days. Persistently elevated ESR and C-reactive protein. So we went ahead with one PET CT. Initially, when we did PET CT, we thought this could be multiple lymph nodes above the diaphragm and below the diaphragm, and as we can see, some chain of lymph nodes and all like that. So we thought the possibility of lymphoma and as well as the tuberculosis. So ultimately, after left cervical supraclavicular node biopsy was done, it turned out to be COX. So most common infectious diseases which can be a possibility of fever of unknown origin in elderly patient is tuberculosis. So where does the PET CT is useful in tuberculosis is initial workup, especially in extrapulmonary tuberculosis, and evaluation of disease extent, multifocal involvement, like because the course of the treatment, that is ATT, depends on the organ involvement. So if it is bone involvement, it may last up to 1.5 years. So at times it guides the accessible peripheral site for histopathological examination, and because metabolic response do occur early than morphological response. So when you want to continue the intensive phase or when you want to stop the intensive phase, early response assessment with FDG PET CT is recommended in some studies for tuberculosis. So the other cause is osteomyelitis, especially in pediatric population. So previously for osteomyelitis, bone scan as well as WBC imaging was reliable, And when you come across with chronic osteomyelitis, especially after trauma or after surgical procedures, so FDG PET CT has a better sensitivity and specificity, especially in post-traumatic osteomyelitis, because it can differentiate the fracture from that of infection. So it is better modality. FDG PET CT is better modality for osteomyelitis, especially chronic osteomyelitis. So the other scenario is infective endocarditis. So generally, patient is usually diagnosed by echo and identification of valvular vegetations, but at times prosthetic valves and small vegetations can be misdiagnosed or can be missed by echo. So PET-CT is a promising tool, especially in prosthetic valves. Here we can see some cases where patient presented with fever. Additional symptoms include weight loss, progressive dyspnea, and all over a period of 6 months. So we did a PET-CT in this patient where we can see uptake in the myocardium as well as in the valves. So after echo, there was some vegetation, small vegetations in the valvular lesions. So later, it was proven as endocarditis. So this is another prosthetic infection. Here, a already known case of prostate malignancy presented with fever and occasional night sweats. Then patient was had a history of aortic vascular prosthesis because of aneurysm. So when we did PET-CT, we had intense uptake in the prosthesis. So the other cause being non-infectious inflammatory diseases. So this is a scenario where a young female with a fever of 2 months, chills and rigors, loss of appetite and weight, and with elevated ESR and C-reactive protein. Montauk test and sputum for AB were negative, and we did a PET-CT which was showing diffuse intense uptake in carotids as subclavian as well as in the aorta and its branches. So consistent with large vessel vasculitis. So both can be possible Jain cell arteritis as well as Takayasu, one of the major cause of FUO. FDG has a better sensitivity even if biopsy is negative in these cases, and it is most effective in determining the extent of the disease and also in monitoring disease response to therapy. So this other scenario is a fever, a patient presented with fever, not responding to any drugs. And then we did a PET-CT. In fact, this patient was a known previous case of CS cervix. That's how we did a PET-CT in this patient. So it has shown increased uptake in subcutaneous regions with consistent with fat densities in whole of the body. So it was diagnosed as a Weber-Christian disease, that is idiopathic panniculitis. So the other cause of FUO is sarcoidosis. So generally they present with bilateral hilar or mediastinal lymphadenopathy. This is a case of sarcoid where we can see right paratracheal lymph node and bilateral hilar lymph nodes. In this case, there were elevated ACE levels, and this patient had a good response to steroids also. So if we have a clinical suspicion of cardiac sarcoidosis, convention FD, rather than going with convention FDG protocol, we have a cardiac protocol designed for a FDG PET-CT. This is one kind of patient where he had an asthma and sleep apnea, and patient also had some ECG changes. And previously patient had a pneumonia which was not resolving. That's how this patient got diagnosed as a sarcoid. Later on, because of some ECG changes and dizziness, frequent lightheadedness and all, there was a strong suspicion of cardiac involvement. So this for this patient, cardiac protocol was used, and initially perfusion imaging was done, which was showing abnormal decreased perfusion in the septum as well as in the inferior wall. Later on, patient prepared according to cardiac protocol, and we did a FDG PET-CT, so which was showing focal on diffuse uptake in the septum as well as in the inferior wall. So this is the same patient. So after steroids, it got responded well. So how will you prepare a patient for cardiac sarcoid is normally the mechanism is immunological cells will have a high glycolytic activity, but cardiac tissue is also will take up myocardium, I mean glucose. That's why we need to decrease that glucose, physiological glucose uptake. That's why a high fat and a low carbohydrate diet is advised. So what Preferably is a fat diet of more than 35 grams and a carbohydrate diet of less than 3 grams is allowed on the day previously or 2 days before to the scan, followed by a 4 to 12 hour fasting. In spite of this, patient can opt for a prolonged fasting over a period of more than 18 hours, and low molecular weight unfractioned heparin can be given. So this is rarely practiced. So these are the preparatory methods what we use before going for a sarcoid protocol when we use FDG PET-CT. So based on this, there is an increase in sensitivity as well as specificity for FDG PET-CT. So these are some scenarios by using perfusion, metabolism, as well as contrast enhanced MRI. So when we see a perfusion defect and a matched or a increased in metabolism, as seen in this patient, with an late gadolinium enhancement and edema on cardiac MRI, so we conclude this, that it is an sarcoidosis with active inflammation. So if there is a mild perfusion defect without any FDG abnormality and no late gadolinium enhancement or edema on cardiac MRI, this is a treated case. Obviously, previously this was a infected and then now it is a treated case. So if there is a perfusion defect and nothing is seen on FDG PET-CT and there was some concordant late gadolinium enhancement, this can be a sarcoid which is inactive right now. So normal perfusion generally rules out sarcoid. If there is any mild FDG uptake, that can be due to non-specific uptake without any significant MRI findings. So the other thing which can be done apart from FDG PET-CT is a gallium doTORNAQ PET-CT, especially in case of sarcoidosis. So why we opt this or more in favor of gallium doTORNAQ PET-CT is that we don't need any patient preparation in the form of fasting or any diet modification in this patient. So what actually happens is inflammatory cells, they have a abundant SSTR expression, especially SSTR2. So that can be picked up by a gallium doTORNAQ PET. So this is a normal gallium doTORNAQ PET in the myocardium. There will be no physiological uptake in the myocardium at all. So if at all any suspicion of inflammatory etiology is there, inflammatory cells do express SSTR that can be picked up by doTORNAQ. So as we know, is a more sarcoidosis is also a cause of FUO. So preferably, most commonly they will be seen with a bilateral hilar or mediastinal lymph nodes that we call as lambda sign. So the degree of uptake on FDG PET-CT also correlates with the disease activity. That's why we use it. We can use it for a response evaluation. So when we have a strong suspicion of cardiac involvement, cardiac protocol is needed when we are opting for a FDG PET-CT, and we can do gallium doTORNAQ PET-CT alternatively without any patient preparation. So the other cause of FUO is that of a malignant etiology. So this patient presented with low-grade fever and tiny cervical and axillary lymph nodes, as we can see in FDG PET-CT. So guided FNAC was done, which was non-conclusive. Then the trial of ATT was given. So it was not responding. Then FDG PET-CT showed above below diaphragm nodes and hypermetabolic spleen as well as diffuse marrow involvement. So excision biopsy was done from that node, which showed as a non-Hodgkin's lymphoma. So malignancies, especially lymphoma, renal cell carcinoma, gastric carcinomas, can present with low-grade fevers. So this is a large prospective study which is done in Germany. So both they have included inflammation of unknown origin as well as fever of unknown origin. So altogether they concluded that so it has a high sensitivity because true positivity of 57% as well as false positivity of 30%. It has a high sensitivity and negative predictive value. And they have correlated with CRP levels. If it is more than 30 milligram per liter CRP levels, the chance of PET-CT utility is much more. It can pick up lesions true positively. So if there is a So the majority of the patients which turned out from this study as infections, uh, lymphoma, polymyalgia rheumatica, and vasculitis, as being discussed now. So the other possible scenarios what we get from a general physicians are patient presented with low backache, X-ray showing lytic destructive lesion in L5 vertebra in this case. So we did a PET-CT. which was showing some low-grade FDG avid lesion in the right kidney, which was later diagnosed to have to be a renal cell carcinoma. So we can see bone lesions here as well as the primary lesion here. So the other thing is a solitary pulmonary nodule. In fact, solid pulmonary nodule. How to characterize this pulmonary nodule and how to follow up this pulmonary nodule. If it is FDG avid, then definitely tissue sampling is needed. If non-FDG avid nodule, if it is less than 6 mm, it can be followed up over a period of 6 to 12 months, depending on other risk factors. If it is more than 8 mm or it is increasing in size in the follow-up scans, subsequent FDG PET-CT is needed as well as tissue sampling. So, to concise, PET-CT is a one-stop diagnostic modality involving whole of the body. So we need not go with CT chest or CT abdomen individually. So it covers whole body. So high sensitive test and high negative predictive value. So it can pick up the lesion as well as it can rule out suspicion. So what happens in PET-CT is because of the anatomic and metabolic information together available, it augments the accuracy of the scan also. So it is an useful technique as well as cost effective because it avoids unnecessary other investigations. It can be used in early diagnosis of FUO and should become a routine procedure in the workup of FUO, especially as previously mentioned when the potential diagnostic clues are absent. Thank you.
Thank you, Dr. Saikrishna. It was a really nice talk, and very you shown it very well how the PET-CT can be used in clinically challenging situations. How can it be, come as a savior to the general physician and practitioners? Uh, Thank you very much. Very nice talk. Dr. Guru Prasad sir, do you have any questions or any comment for Dr. Sai Krishna or any other message if you want to add on? We would like to hear from you.
Yeah, see, the presentation was pretty. It was quite lucid, and I think it answered most of the questions which we had in our minds.
Sir.
I don't think anything else is from my side.
Okay, sir.
I think I think it's more or less clear about what are the indications for a PET scan and when to use PET scan as a
Correct.
diagnostic modality.
Correct, sir.
Thank you, Dr. Sai Krishna.
Thank you, sir.
Thank you, sir. Thank you, sir. Just one thing from you, sir, Dr. Guru Prasad, sir. Sometime we do get a referral for a PET-CT scan, like after completion of AKT. Uh, I don't know why it comes because the patient wanted or the clinician expect us means to just document it that there is no active disease remaining. So just want to know, is it a guideline based thing or it's just person to person, individual practice dependent that before stopping the AKT, they just want to document that there is no active disease? And how do you look at it? Do you regularly or
Yeah,
sometime?
see, the thing is that with tuberculosis, it's a very funny disease.
Yes, sir.
The patient becomes all right clinically within 2 months of the intensive phase gets over. The
Correct.
patient becomes all right. There
Hmm.
is no guideline, national, international, which tells us to repeat a modality like a PET scan to document remission of the disease. But
Correct.
a lot of clinicians do ask for a PET scan because the patient says, "I've been fine for the past initial 2 months only, but I've been taking ADT for the last now another 1 year. How do you say
Correct.
I'm completely cured?" Generally, we look at inflammatory markers like CRP, ESR, and they're indirect markers. But
Correct. Correct.
a PET is something if it's like abnormal before and there's regression of lesions post ATT, it gives us more confidence that we have done a successful remission in the patient. But there is no guideline actually anywhere. I agree with you.
Fair enough, sir. Yeah. Sometimes we have to use, few things in clinical practice that may not be there.
Yeah,
That's how it
yeah,
is
yeah.
probably.
yeah.
Yeah.
In
Yeah.
fact, I would quote here one case where we actually diagnosed a drug-resistant tuberculosis on the basis of a repeat PET scan, which still showed activity in the lymph node. We did a
Hmm.
re-biopsy and sent culture of the node, and it actually turned out to be a XDR TB. And
Okay.
then we got to know that the patient actually was missing drugs on Saturday and Sunday because he used to come to, he used to go to meet his family in Varangal.
Oh.
So he used to miss his drugs during those 2 days.
Mm-hmm. Nice, sir. Fine, sir. So I would like to conclude this now. I'll thank both of you, Dr. Guru Prasad sir, for your valuable time, and Dr. Sai Krishna for your time as well as some insights about PET-CT. I'll just check once if there is any online questions. As of now, no. So anyway, we'll close up here. But if anybody who hears it have any question, can post their questions on Vijaya handle on social media, and we'll be happy to answer those questions. So thank you very much once again. Thank you, Dr. Sai, Dr. Guru.
Thank you, sir.
We'll end the session here. Thank you.